Our next presenter is Ben Waller. He's from Brighton University, received his physiotherapy licensure there.
Yes.
He then moved to Finland, and he's received his master's there with biomechanics emphasis and physiotherapy emphasis, and now he's also working on his PhD at the University of Jyväskylä. His research focuses on the effect of aquatic resistance training on the biochemical composition and morphology of cartilage in postmenopausal women with mild osteoarthritis. And today he's going to be speaking about the first annual European conference. And we look forward to having this presentation. So join me in welcoming Ben Waller.
Thank you. First, I'd like to thank the organisers for inviting me here. Very, very good opportunity for me to come over from the land of Finns to America, first time over here. I've really enjoyed myself. I've eaten far too much. I've learned some fantastic new words, such as awesome. I only used that when I was 15, and now I use it again every single second word. It was actually a privilege to be asked here. And it's nice to know that we've got some links now. I'm starting to build up some more links between Europe and the other side of the Atlantic Ocean, because you guys are doing fantastic work. I think we're doing fantastic work, but there does seem to be still a little bit of a communication breakdown. So it would be fantastic if this is the start of a beautiful relationship, to start exchanging ideas and views, because you guys have got some great ones, completely different to what we use. So it would be great if that could be the start. But my presentation is going to be on the congress we held in Izmir, Turkey, in March this year. It was the first evidence-based aquatic therapy congress. And actually, it's quite a difficult thing to present for two reasons. One, it's not my own data, and I'm much happier presenting my own data. But two, how do I cram 5 days of intensive discussions into 40 minutes and make it worthwhile as well? So hopefully I can get all of this data out, but we'll see how it goes. So who am I? I've got a good introduction. I am also a clinician. I run a small sports rehabilitation service in the pool. It's basically all I got when I moved to Finland. That was what I got the opportunity to do. I was a neurological physiotherapist in the UK. When I moved over, got the opportunity to work with a sports medicine clinic. So started rehabilitating athletes in the water. I then progressed to getting patients from the local hospital with fibromyalgia, chronic pain, low back pain. And so I started to treat a nice wide range of patients. But next step is going into the neurology, but that's controlled by the state. So I've got to apply for a license next year for that. But that's the next goal. I'm trained in Balcova ring method, Halluix water-specific therapy, but also I use a lot of other techniques. I was the physiotherapist for the national swimming team in Finland for about 4 or 5 years, worked with the junior teams. So basically anything that's gone in the water, I've kind of tried to have a little bit of experience in. So what that means is that now I'm doing my PhD, I have got a good idea of what clinically we would do and also what happens in research. And I've still managed to keep these two little birds sitting on my shoulder. One's my clinical bird and one's my research bird. And they peck me to pieces and have a good old discussion, and they always fight about what's best. So it's now, I now got a good idea of what we do, and hopefully this can then go on to the next stages. But as we had a fantastic presentation this morning about current research doesn't necessarily complement what we're doing in the pool. And unfortunately, we go and use those randomized controlled trials as the way of getting money, and they don't always meet. It's a really difficult situation at the moment, but hopefully with new advances in research techniques, acceptance of these techniques, we can then take forward and do much more effective research, which will then impact clinical practice. And this is going to be required, the clinicians and the researchers, to talk the same language. So this was the brainchild of, the Congress was the brainchild of Johan Lambach. I'm sure most people are aware of his name, who he is. We got sponsored by the university in Izmir, the first people that decided to go forward with the project. So that's why we went with them. And Johan was the head of the scientific committee, then Barish was the head of the organisation committee. And I have to say that having a guy staring at you as you present from behind you is rather off-putting. But he's very big in Turkey. He's a very, very important guy in the Turkish history, which is why his post was there, but it was a bit off-putting. We had 150 delegates, 30 different countries, 8 keynote lectures, 20 short oral communications. I think it was about 60 different poster presentations, and we had such a diverse subject base. I mean, we had from neurology to orthopedics to aquatic health, water health, different techniques, outcome measures. It was from one end of the scale to the other. And it was brilliant. Every single level of research was represented. Every different area of research was represented. And because it was such an informal congress, we had this fantastic chance to discuss. The bar was the best place to discuss this thing. And we had spent hours debating and talking, had clinicians, researchers, and it was just really good to hear other people's point of view, look at the research and get feedback and interact. And that's what we need. We need that ability to interact. And so this is what it gave us. We had pre-congress teaching, which was really good yesterday. All you guys talking about the treadmill, the cognitive training, etc. We all had that as our application of aquatic therapy in practice and research in practice. So I've got stuff in here which I'm not going to talk about now because you guys who are more qualified than me spoke about it. So I'll just touch on it, but I won't go into any details. So we had it again today, different levels of research. And these were all represented. But again, level 1, RCT, or systematic reviews are the ones that we put forward to try and change policy. And they're not the ones that represent what we do in clinical practice. So luckily we also had a lot of and I don't like low quality or high quality, I don't like this terminology, but this is what it is at the moment. This is what we base our work on. Expert opinion, first principles, case studies. This is what, again, repeating again what we said before, this is what we need, and this is what we had. I want to talk a little about a systematic review. So the WHO requested that we do a systematic review of all the literature out there for health benefits, for spas and pools. So we collected all the data. So we created a team, and we presented the data that we had collected at this presentation. We had a panel discussion. I was sitting on the right hand of Bruce Becker, which apparently is a very big privilege. Fantastic man, really liked it. But it was the work that I did was on musculoskeletal, and I'll present that in a second. But the idea was to demonstrate what is the current literature for health benefits in the pool. And we used the WHO's ICD-10 classification of diseases to work out what groups we're going to research, what were main groups we were going to extract the data for. And this is our group, the subjects that we had. I had musculoskeletal, sports rehabilitation. Bruce had physiology, cardiopulmonary. We had Paola Gargoyle with us as well. So we had a few guys from the US, one lady from Australia, UK, Belgium, Hungary, France. We tried to make it across the board from all different countries. Unfortunately, it's really difficult to meet. And then I did this. I am proof that I was actually there. And so I did a search. I did a search for all these different diseases, used what would be considered the best keywords, and did through 6 different databases that I had access to. And this is what I came up with. This is the top cut. This was done to the end of this year, end of last year, 2012. This is all the data, all the RCTs that have been published in musculoskeletal. So that's joint replacement, osteoarthritis. We included ankylosing spondylitis, rheumatoid arthritis, and a couple of others. Low back pain, obviously. That was a funny one, low back pain. I've done a systematic review on low back pain, and I had to include non-randomized controlled trials just to get a complete summary of what interventions have been used in there. And this is what's the problem with randomized controlled systematic reviews, is they narrow down data. So you get smaller and smaller and smaller, and you get to one outcome measure that they present. Systematic reviews are quite good to tell you what the data is out there, but they're only just to tell you to go and read those articles and assess them for yourself, because a systematic review, and I've just about published one, is in my opinion, a good direction, and I'll come to that in a minute, what their conclusions are, but you have to be quite careful. And this is what I did. So if you think about this in general, it's actually quite good. Look how the research has been increasing. From 1990 to 2012, there's a serious increase here of good quality, or fairly good quality articles published. But still, if you were to go through 1 month for low back pain and do an exercise intervention, you would get twice this each month for low back pain. So although we've got some research, again, it supports what we've been saying before, that the research out there is quite superficial and doesn't necessarily always tell us what we want to know. But this is not in your handout. This is my unpublished systematic review, which is in the PTJ at the moment under review for osteoarthritis. So I found that aquatic therapy is equally as good as as in pharmaceutical interventions and other aquatic exercise, land training, whether it's aerobic, strength training, etc., which is good. It's as good as the same. And this is what we found across the border, that it's the same as land training. You're not better than, not worse than. And so the question is, well, what are we researching? Just to summarise, the effects decreased after 6 months. So we have this problem that aquatic therapy does produce good training, but what do we do afterwards? And this was the same across all the other diseases that we looked at across the board, neurology, etc. Most of the time, after 3 months or 6 months following cessation of the intervention, the effect was gone. So there needs to be something on the next step. What is the next step? What advice do we give the patients? What do we offer them? Is it something in the pools, like a training in the water, something else, something next? But it's quite clearly that you stop the exercise and the benefit decreases. So, as I say, it's effective. And this is what we did. This is a systematic review. It was good, and we had them for all the different conditions. And like I said, the results were the same. It's equally as good. And then this fun thought. How many times have you heard this? Further research is required to support the use of this intervention in this disease group. Great. That is the end statement of most systematic reviews. And what I tried to do with my systematic review was say, okay, we need more research in this, and this. This is what we're doing, this is what we need, and direct the next level of research. But most people just go, who do a systematic review, just say, okay, we need more research, more high-quality research. Okay, we do need that, but we also need research to tell us which patient group will benefit more from aquatic therapy compared to land training. Which patients, how can we differentiate the patients that will benefit most? And that's the research we need. How can we choose this patient should go in the water? How can we give the easy choice for the physicians prescribing or referring the patients to aquatic therapy? This is the ones that we should be treating in the water. So that was that. So that's a big systematic review. It's going to be published fairly soon, hopefully. And then we went down to a different group. So outcome measures. We spoke about it today. I gave a little bit of my opinion. We have got a research group or a little collaboration in Europe. Hopefully we can expand that. But we had some really good presentations on outcome measures. So we had one by Ollie, a guy from the UK, and he devised a standardized collection tool for aquatic therapy with patients with multiple sclerosis, a clinical tool to collect data to allow researchers to assess the impact of the treatments he gave. He presented that. I've got a copy of it in a minute. We then had Jackie Patman presenting a patient-specific outcome measure, which is used generically across the board. It's a 2-question questionnaire. We do it all the time. What are your own aims? I've got this in a minute, I'll show it again. And that showed that aquatic therapy across different diseases worked. She could combine the diseases and use the same outcome measure, and it was specific to that patient. And then we had different outcome measures, cross-cultural adaptions, some systematic reviews of what outcome measures were out there, and then we had a guy from India, and I'll go into his work in a minute. He talked about the appropriate selection of outcome measures, or that was my interpretation of his case study presentation. So this is what this was the data collection program. I cannot give you this because the researchers didn't let me give it to you, but it will be on the UK CSP physiotherapists website to get fairly soon, or if it's not already done, but I couldn't find the link. So all the work that the guys in the UK are doing will be accessible in the near future. But he had basically very simple name, specific outcome measured, validated outcome measured for that disease. So in this case he had fatigue impact scale, POMA, and a question of quality of life scale, and then differentiations of different types of intervention, how often they were given, what type were given. And then this was fed into a computer, and then they collected data on how good their own clinical work was, with what patients, what background, and they were able to extract exactly what was going on. And took 6 weeks intervention period, because that's what they would get, and they got the results. So it's really, really good tool, and the guys in Brighton University, from where I did my original training from, are doing more and more of these kind of data collection tools, which can be used across the disciplines. This is my mop. This is what Jackie did, and this was the patient-specific. And basically all it asked is a couple of symptoms. What are the main symptoms for you? And then a particular activity, one outcome. What do you want to achieve? What's the biggest problem? Is it getting from the chair to the toilet? That was specific to the patient. And it means that you don't have to give the patient a task that you've already fit. If it's a get up and go, or is it tug test, or is it something like that, it's specific to them. And then there's just a follow-up form for the outcome. This is free on the internet. My mop too. You can use this. This is why I present these. And then we come to our colleague from India. He presented a case study about one patient who had Guillain-Barré syndrome, and she came into treatment, had 4 weeks, 5 weeks, or 5 months in intervention in hospital, discharged, didn't get treated again, and came back to treatment. And what's great about this story is that any other treatments she had tried didn't produce any outcomes, any changes in her condition, but the aquatic therapy did. And that's where his story is, that with this patient group, it was great and effective. But what I actually got out was that the same group of people use the same outcome measures, so they could track the patient. So the whole care group, from physician to the clinical out there physiotherapist, knew exactly what outcome measures had been used them again and again and again, and they could see the improvements and could compare the improvements between different interventions. So again, if we're using different outcome measures, we're on our own. And this is why I made the comment earlier this morning, that we can all use the same outcome measures, then it's good. But what is an aquatic therapy? So we have got a little study group going on. We meet a couple of times a year, mainly by Skype, but we've extracted all the outcome measures used in aquatic therapy. It's kind of like a continuation of the thing we did in the WHO. And we've extracted all the outcome measures that they've used. We've extracted also all the outcome measures that have been used in dry land, looked at the quality of them, the reproducibility, ease of clinical use. Had some guys from Holland come down. And so we've been collecting this, and we've actually made guidelines not that long ago that's based on other people's outcomes that have been used, but also what's been used in aquatic therapy. Now, the biggest problem we have is that they don't necessarily measure what we're treating in the water, that the ones that have been used in clinical research. They're the ones that that research group have been familiar using. It's not the ones that best suit the intervention. So what we've been trying to do is create a list for different parts of the ICF of what you could use. Now, we've got a list. We haven't just got one. We've got a list of different things, different measures, different areas. But they're also the ones that have been used in exercise interventions, drug interventions. So we can try and combine them. So it's just a little project that we've got, but it needs to be developed, and we need more input from other people. So that's one thing we presented there as well. So then we went to ventilated patients. Move on from our outcome measures. Ventilated patients. Acute aquatic therapy. So we know that aquatic therapy is effective, especially for those that have difficulty moving. And in the acute medical position, so like they've had a respiratory disease and they can't move, more often than not, they're not going to get prescribed aquatic therapy, especially in where I come from, in the UK or Finland. So this was a case study. It was just presented to say we took this ventilated patient into the water, straight from the ICU, with breathing control on. We had a big team to do it, but the benefits were fantastic. And this is what we're talking about, case studies. If you don't know this, you can't do an RCT on ventilated patients in the pool. This is not going to happen. You're going to spend 6 years trying to get the patient group together. So these case studies are invaluable. And they were saying the benefit of this one patient going into the water was huge. We know it. But she still hasn't published this. And this is what was the problem, is that we need to have an outlet for these case studies. We can say, go write them. How do we get them out there for everybody to be able to read? If you put them into a journal that is only in one country or is not accessible free, clinicians do not have the ability to go through these search engines. So somehow we need to create maybe another journal, get sponsorship from outside to create almost like a case study journal or something like this, that we can push these articles out quickly so that everybody can read them, everybody can see what other people are doing. Without that, we're not going to be able to see it. So, this is in Holland. I wanted to show you... Oh.
Nijmegen has the addition of a unique swimming pool, a swimming pool of only 5 by 5 meters. Not unique because of its dimensions, but because it's built in the intensive care department of the Radboud Hospital. Patients having lost their muscle strength because of prolonged bed rest can now begin the process of rehabilitation much sooner than usual. They no longer have to wait until they are discharged from the intensive care. Mr. Buys is going for a swim, or in correct terms, he's going to hydrotherapy. After suffering from a severe heart attack and undergoing surgery, he has been in bed at the ICU for many weeks. His muscles are now so weak that he can no longer sit, stand or walk. To regain his strength and mobility, he needs to move, the sooner the better. An Ewik medical swimming pool is the ideal place for him to do this due to the buoyancy of the water, which makes it easier to move. But until now, intensive care patients could not benefit from this opportunity due to life support equipment they were attached to. In Nijmegen they have found a solution, a swimming pool where equipment and personnel can simply join the patient. In respect to the standard rehabilitation exercises that we conduct here at the ICU, this method allows us to begin exercising much earlier than usual. So for people who have a very limited strength and mobility and are virtually unable to move their arms even against the weight of gravity, they're able to do this quite well in water. What we believe is that if you are able to train from an early stage, patients can leave the hospital healthier and their chances of survival will increase. Because Mr. Buys is actively ventilated, he is unable to speak, but a discharged patient who has previously undergone this treatment after being under sedation for 7 weeks with a lung infection says the treatment also has a psychological effect. After they let you float for a minute, they help you up and all of a sudden you are standing on your own 2 feet again and even walk. This gives you confidence again because you are used to not being able to do anything. When you're in the water, you realize that you can, and this gives you the confidence that you will be able to learn and do it again on dry land. Mr. Buys walked 10 laps in 10 minutes, a brilliant performance.
So just think about having to show the evidence for that. What is there out there? Well, we fortunately had somebody again from the UK, Susie. She presented the work that they've done in the UK. That it's just been published on the internet. And this is it. Risk assessment for patients with tracheostomy and ventilated patients. So what did they do? They just looked at all the evidence out there, took up all the case studies, looked at all of them and used that, and then did an Delphi discussion with experts in the area and discussed between them, well, how do we take this phenomenal opportunity forwards? Because you're not going to find the data. So this is one way that case studies and getting them out there are very important. And the quicker you get them out there, the quicker they can maybe stimulate researchers' ideas, get funding for it. But I cannot imagine trying to go to my local hospital and say, yeah, I've got 3 case studies, give me a pool in the ITU. So this is a really good document. Gives you an idea about how to integrate the lower level evidence to create change in clinical practice. So, and then we had bringing evidence closer to practice. We had these 4 training groups at the beginning of the Congress. And most of them have been discussed. We had bike, we had treadmill, we had I Chi, we had Balcova, which I did, and Hollywood in pediatrics. And so we had the big practical side, but at the beginning of it we had a theory session where we went through all the research, whether it's land or water in this area, and applied all of the different evidence that you could find for this. So it was evidence-based practice, and there were different levels of evidence. And one was the mass practice in urological rehabilitation. This was really interesting for me because we had that presentation earlier on yesterday about the changes in the neurological system, the activation of an enriched environment. What does it give the patient more than a boring 4x4 room, lift weights or do an abdominal training? The pool theoretically gives us an opportunity to give them an enriched environment, whether they're doing a basic task or they're not doing anything, but the environment will theoretically stimulate better neurological adaptations. Now, so far, it's all based on with rats, mice, or a few land-based interventions. But luckily, we had one guy present new data for an aquatic intervention at the Congress. So I'll come to that in a second. So the environment is enriched. I don't need to talk about it. We love the environment. We know what it's good. We've spoken about it for the last 3 days, so I don't need to go into this anymore. And then we had the treadmill. And I was just discussing it with my colleague here, that treadmill walking for post-stroke patients would be fantastic, get them going quickly. We also discussed how uncomfortable, especially for men, those suspension walking systems are, ball breakers, as we decided to call them. And how potentially treadmill walking. We've spoken about earlier yesterday about the biomechanics, the kinematics and kinetics about treadmill walking, but we haven't spoken about the health benefits of treadmill walking. And these guys have done some of the work already, and this is one area which I would love to see much more work done in. What is the health benefits of walking in the water? Because I myself believe that it's huge. The gains of doing what we are built to do is walk. It's not sit on my bum, not sit in ice water, it's walk. So I firmly believe as a research, as a treatment technique, it's got huge potential. But I'd love to see, again, the more research on it. But it's cool. I mean, I'd love to see it done more. And as for obesity, thinking about getting those patients training at the right intensity. Okay, we had some this morning, maybe against what I'm saying, but okay, training in the water. With the WHO, Johan found that, again, with BMI was reduced in aquatic training, risk factors for diabetes and other obesity-related diseases, the markers were decreased in aquatic training. We've got some research out there. It's not my area of expertise, therefore I'm not going to go into much further, but there is good evidence to suggest that these markers for these diseases, which are becoming our main treatment techniques or main areas of research, are effective, and we can treat them in the pool. We had the bike. Now this was really interesting. One other piece of data before I go on, and Alison Boneyman from Canada, there on the other side of the bike, asked me, why do we take them into the water to do the bike when they can sit maybe on dry land and do the bike? If they can sit on dry land, why do we take them into the water? What is the added benefit? Is there any evidence to show that cycling in the water has an extra benefit for a patient group than others? Because, you can cycle on the dry land. Luckily, we had Jens there. He's done 2 studies. One's been published, and the second one should be published fairly soon. This was the one that's under review. He looked at brain-derived neurotrophic factor hormone with MS patients in a high-intensity bike training. So they did high intensity. He used the word beasting. We sometimes treat our patients maybe a little bit too gently. And these guys were training. They did VO2 max tests. These theoretically tired patients with high fatigue, they would do VO2 max testing and then push them in the water. But then he also had a comparison group in the dry land doing the same level of intensity training based on VO2 max testing on dry land. So he had the comparison group. And he found that those who trained with in the pool with the bike had significantly higher levels of the neurotrophic factor. So in fact, just by being in the water, there was a serious and a significant difference in the neurological system, just by training in the water. A repetitive movement in the water. So this has great potential. These kind of studies have got great potential to push our profession further into the active range. We go, okay, they could do it on dry land, but we've got something added, and we've got proof we've got something added to it. So that was a fantastic article. Again, quality of life improved, fatigue factors decreased, cardiovascular functions improved, and all they did was cycle in the same intensity in land as in the water. And those articles are to get. There is now all the abstracts have been published, free on the internet. The link is in your page. So if you want to read more, you want to find out which authors published what, and you want to get into contact with them, find out more details, because I can't tell you everything about everybody's research there. But if you can't get in contact with them, contact me, and I'll send them the details forward. So that's what we had. So the ECEBAT was fantastic. It was a good start. We did things wrong. But to be fair, it was the best 5 days in my aquatic research life, and maybe clinical as well. We had debates, we had arguments. People that are so passionate about their interventions and their treatments that they can't believe that researchers are saying that's wrong, or we can't prove it. And they see researchers as negative and practitioners as positive. And what we're saying is, we're not negative, but we take a step back. We think about it. We want to make things better, but we don't always take things on face value. We research it. That's what we do. Great research going on in Europe. I think that it was lightly represented by actually what's going on in the world, what I know what's going on. I'd love to get the guys from Utah. It's at Iowa as well. They did some aquatic training. Some of the work you guys are doing needs to be represented next time, because the integration and the exchange of ideas, sitting over a nice glass of wine. You can present to your blue in the face, but it's the discussions as well afterwards. It was the best bit for me. I didn't think I slept for about 4 days. And again, one of the big arguments was, what are we treating, why are we treating, and how are we measuring it? Those were the questions that came up. So the next Congress is going to be in 2015 in Leuven, Belgium. I think it's going to be 1 month after the WCPT in Singapore. We didn't want it to clash. It's easy for you guys to get to. I checked that there are flights going from the USA to Brussels. 20 minutes from Brussels. And if this is any motivation, it has the world's longest spa in it. It might motivate you, it might not. But I'm there. So the future challenges. We hope to get this divide broken. I don't want to hear any more those in the trenches and those doing research. We have to combine, we have to talk, we have to communicate. This is a good start. And one of the things that I'm starting up with the WCPT is we have an Aquatic Therapy International. Do you know all about it? World Federation of Physiotherapists has now got a network for aquatic therapy. We have been emailed. We do have a contact name for the USA, but we did a survey. We got 3 replies from the US. So it's quite well represented now in Europe, South America, but we need more input from you guys, more integration. So it would be fantastic if we could do more of that. And we've got basic tasks, and one of the things is to create interaction. So what I did is I've got all the addresses of people that are registered for it, and I emailed them a quick questionnaire. And I asked them, what do you want from us? What do you want us to do? And we had 110 replies, 3 from the US. I think for the number of qualified aquatic therapists, I think you have the highest in body in the US by a long, long way. And yet you had one of the lowest representations on this group, which is probably just due to not knowing about it. Well, now you do. So what I would love to do is start integrating, discussing with your bodies, especially the American Physiotherapist Group for Aquatic Therapy. I'd love to discuss with those and get some with you guys to get some integration, some cross communications, hear what you're doing, because that's what we need. We need to open the channels. You know, some things we're doing are wrong, some things you're doing are great, and we need to be able to work out what they are. Use all the good things. No point reproducing what somebody else has done. If I've done something badly, I want to tell you that I've done it badly, and so you don't repeat it. You go on to the next stage. And so one of the things we've got is this International Aquatic Therapy International LinkedIn site. It's hopefully soon going to have a research section on it, either this or this website. I'm going to try and create a research section where you'll get links to research methods, outcome measures, experts in the field who are doing research in aquatics in this particular area. So you can contact them and ask questions and try and build up, again, these links. Because research grants are getting smaller and smaller and rarer and rarer. And in the end, we do a lot of research that doesn't get out there. It's either not of the highest quality or it's not being planned properly. And what we need to do is integrate these resources to do the piece of research we need for our profession that will get our profession going forward, that will get the insurance companies paying the funding. And that's what we need. And if we're all doing the same thing all at the same time, it's a waste of resources. So somehow some kind of collaborations is what I'd go. And obviously this is going to take time. This is going to take a long time. But we've got to start somewhere. So I'm going to put myself out there and try and take this forwards. I'm not a professor. I'm not yet PhD. But it's what I hope to do. So remember that all this data is produced by permission given of the original author. Link to all the abstracts is there. And thank you. "40 minutes.
Okay, great time. We have some time for questions.